My name is Shah. I'm a radiation oncologist. I serve as the director of breast radiation oncology at the Cleveland Clinic. When it comes to deciding upon partial breast irradiation, it's important to recognize that partial breast irradiation therapy incorporates multiple techniques. These are typically broken down into brachytherapy, external beam radiation therapy, and intraoperative radiation therapy. With regards to brachytherapy, there are several techniques that can be utilized. The most classic and oldest partial breast technique is interstitial brachytherapy. This is when we place catheters through the breast, often with ultrasound guidance, in and around the lumpectomy cavity. This has been studied in several randomized trials, including 20-year data from the Hungarian Institute for Oncology study, which found no difference with this technique as compared to whole breast radiation. Similarly, the JEC-ESTRA randomized trial, which included more than 1,400 women, found no differences in rates of recurrence at 5 years between interstitial brachytherapy and whole breast radiation. It's important to recognize that with interstitial brachytherapy, techniques including high dose rate and low dose rate brachytherapy can be utilized depending on the center. Applicator brachytherapy involves placing a device, often a single entry device, into the cavity. This is most commonly placed after surgery, though in some studies has been placed at the time of surgery. The original applicator device was the Mammocyte single lumen device, which was evaluated in the Mammocyte registry trial, and at 5 years had low rates of local recurrence. While applicator brachytherapy has not been evaluated as the only modality in a randomized trial, it was evaluated and included in the NSABP B39 trial. Since the inception of applicator brachytherapy, there have been evolution of applicators and techniques allowing for multi-lumen or multi-catheter applicators, which provide greater degrees of freedom, allowing for skin sparing as well as chest wall sparing. Additionally, applicators such as the strut-adjusted volume implant have allowed for the removal of a balloon and a more interstitial-like applicator device. Finally, with respect to brachytherapy techniques, more recently, there's been the evaluation of permanent low-dose rate implants. These have been studied in several institutional studies and have shown promising outcomes, though long-term outcomes are limited at this time. With respect to external beam radiation therapy, the original technique was a three-dimensional conformal radiation therapy technique. This technique used multiple beams and provided radiation therapy twice daily for 5 days or 10 treatments, with the treatments given 6 hours apart. While initial outcomes at the institutional as well as prospective study were promising, longer follow-up has shown this technique to be associated with higher rates of side effects, including side effects such as fibrosis in the breast. More recently, studies have looked at altering both the dose and fractionation as well as the technique to potentially mitigate some of these side effects. The University of Florence randomized trial used an intensity modulated radiation technique, but also changed the regimen from a twice daily to an every other day approach. Using this technique and this fractionation pattern, the study found reduced rates of acute and chronic side effects as compared to whole breast irradiation. Other studies have used 3D conformal partial breast irradiation, but have changed the fractionation to a once daily approach and found also low rates of side effects. This has not been evaluated with a randomized trial. Finally, intraoperative radiation therapy has been considered as a partial breast technique. This can be delivered at the time of surgery and as ideally not requiring whole breast radiation, with around only 10% of patients requiring additional whole breast. This technique was evaluated in 2 randomized trials. The first was the Elliott trial, which evaluated electron intraoperative radiation and found higher rates of recurrence as compared to whole breast irradiation at 5 years. Though a subset analysis of suitable patients based on ASTRO criteria did find low rates of recurrence. The Target trial evaluated low energy intraoperative radiation. The original study, published in 2014, demonstrated increased rates of recurrence with IORT, though within the non-inferiority threshold. However, IORT given after surgery or post-pathology had higher rates of recurrence exceeding the inferiority threshold. More recently, updates of this study were published. However, it's important to note that this study did not publish the entire trial as one cohort, and so it's unable to be evaluated as a technique at this time without long-term follow-up. It's important to recognize that current guidelines from the American Society of Radiation Oncology and American Brachytherapy Society provide caution on the use of intraoperative radiation therapy outside of studies at this time.